Donc, bonjour et bienvenue à
So
tous dans notre
welcome
de
to
discussion.
our discussion
Je suis
group.
Tania McDonald,
My name is
directrice
Tanya
à SRC
McDonald.
Santé Canada.
I
Et
am
je suis
a
vraiment
director
heureuse
at
aujourd'hui
Healthcare Excellence Canada,
d'animer cette session
and I will be your
de mon
moderator.
bureau à Ottawa
I am moderating the session from my office in Ottawa on the
Anishinaabe.
unceded territory of the Algonquin and Anishinaabe Nation.
Bonjour et bienvenue à notre groupe de
So
discussion
welcome
d'aujourd'hui
to
sur
our
la prise en
discussion
charge des
group
ayants
on the
besoin
care of
de
older
soins
adults
médicaux
with
et sociaux.
health and social
Je
needs.
suis accompagnée aujourd'hui
I
par
am with
Rouleau,
Rachel
du
Rouleau,
département de
who is
pharmacie,
Associate
enseignante
Head
en
of
recherche,
the
chercheuse
Pharmacy
associée à
Education Training and
l'Institut national
Research
des malades
Department and
au Centre
Associate
médico-universitaire
Researcher
de services sociaux de
at
l'hôpital national.
the
Bonjour Tania. Bonjour à tous.
Sustainable Health Research Center
Cette
at the
discussion
SUS de la Capitale
va se
Nationale.
dérouler en français
Today's
et
discussion will
avec
be
interprétation
taking place in
simultanée.
French.
Donc,
We're
si vous
offering
voulez
simultaneous
choisir
interpretation into
la langue
English
dans laquelle vous
if
souhaitez
you
participer
wish
à
to
notre groupe de
select the
discussion,
language in which you'll be
joignez-vous à
participating
notre
in this discussion
conversation
group.
en vous
Please click
dirigez
on the
au bas
interpretation
au
option
bas de
in
l'écran.
your Zoom menu at the bottom of the
Durant la
screen.
prochaine
So over
environ
the,
30 minutes,
well, we'll say 20
nous
to
allons
30
partager
minutes,
avec
we
vous
will be sharing with you
les programmes en cours ici
some
à
highlights
Santé Canada
of
en lien avec les
ongoing
soins
programs
aux
at
âgés
Healthcare Excellence
et les
Canada
services
related
sociaux.
to the care of
Le
older
cadre
adults with health and
d'accompagnement
social
est
needs.
Opus AP
Our
provincial
collaboration with the
dont je vais
Opus
parler à Rachel
AP
pour
PEPS
discuter
process
davantage
in
et
the province of
aussi
Quebec, and I'll
pour
turn the meeting over to Rachel to talk
pour
about
les
that.
propos pour
And
identifier
we
les
will
faiblesses
also
dans le
be
système et
seeking to
identifier
identify
des solutions.
current challenges and solutions
Donc,
in
tout au
the
long de
system.
cette
So
donc moi et Rachel, nous allons
Rachel
présenter
and I
et
will be
répondre à
presenting
5
for
questions
about
avant et
5 to
ensuite on va
10
ouvrir la
minutes,
discussion
and
au
then
groupe.
we
Donc,
will
pendant
be
que
opening up the discussion.
Rachel
So while Rachel and
s'exprime sur les
I
réflexions,
are
si vous avez des
exchanging
anecdotes à
some
partager avec nous pendant cette discussion,
presentation
vous
items,
pouvez
if you
nous
have any
envoyer en commentaire
anecdotes
sur la
to
catégorie
share,
visant les soins
um,
et services aux personnes âgées
anything
en
that you
vous
would like to
encourageant à
share
partager
about
dans
your
la conversation
experience
en anglais et en
on
français. Donc, on
um,
va s'en servir pour animer la discussion.
what could
Après notre présentation,
provide
on va ouvrir
leads
la
towards
discussion avec
significant
si
improvements in order
souhait pourrait
in the area of
recevoir
care of
une amélioration
older
des
adults with health
services
and social
au
needs.
niveau des soins aux personnes âgées
And then we will open up
dans les
discussion on
CLSC.
the same topic.
À ce moment, nous
And
allons
at
vous
that
inviter
point,
à
you will be
partager
invited
vos
to
réflexions, vos pistes de
share your
solutions
ideas, your
dans le
reflections,
chat.
your
Et moi et
proposed
Rachel, nous
solutions
allons
in the
toujours par la suite animer la
chat,
discussion.
and Rachel and I
Donc,
will
comme on le sait tous, la pandémie
take
a
that as a
impacté
starting point for our
durement la
discussion.
société
So, as we all know, the
canadienne
pandemic has had a
et a
major
mis en
impact
place
on the
auprès de
lives
nos
of all
communautés
Canadians, and
de limiter
especially on
nos soins non
older
urgents
adults
aux
within our
établissements
communities,
où les personnes âgées
as well
sont
as
résidentielles.
health, long-term care and other institutions.
L'objectif de la santé
The
physique
pandemic has
et
had
mentale
negative
des
effects
personnes âgées due
on
au risque
older
d'aggraviter
adults'
la santé
physical and mental
psychologique,
health, given
ainsi que
the
les
increased
effets négatifs
risks
sur
related
la
to
santé
the
mentale
transmission of
liés au
COVID-19, as
isolement,
well as negative
l'isolement,
effects on mental
le
health
confinement et les autres
due
mesures de
to
santé publique
loneliness,
visant
isolation,
les gens les plus à risque.
engendered by
Comme mentionné dans notre
lockdowns and
introduction, on
other
a prévu
public
une
health
stratégie
measures
spéciale
designed to
pour
protect the most
stabiliser
vulnerable.
les
So,
soins des personnes
as
âgées
we were
dans les
saying
prochaines
in the
années.
plenary session, one of our
Et ce, sous
strategic priorities for
l'objectif
the
de
next
stabiliser
5 years will be
Priorité
care
stratégique
for
a été
older
identifiée
adults with health and
et
social needs. And this is
nous
throughout
mentionnant
the continuum of care. This strategic priority has been identified and
Comme je vous le
validated
disais aujourd'hui,
during
les personnes âgées
pan-Canadian
sont
consultations related to
représentant
our
environ
strategic
18% de
development.
la population.
Older adults over
Notre
65
mission
make up about
est vise
18% of the
à
population. Our population is
réduire
aging, as we
plusieurs
know,
défis au
and
niveau
there are
des
a number of
inégalités et
system-wide
des inégalités
challenges
qui sont
involved in
connues
providing quality care. And those challenges
depuis longtemps
have been
et
known
qui sont
for a
sécurisées.
number of years.
Malgré le fait que plusieurs
Even
personnes
though
vivent avec des
many
troubles
older
physiques et
adults
mentaux,
live
l'espérance de
with
vie
chronic
augmente.
physical and
Donc,
mental illnesses, their life
on est
expectancy has
allé
increased.
à travers le Canada et on a
So
décidé
we have
d'inclure
listened
cette
across Canada and we
stratégie
have decided to
dans nos
include
priorités stratégiques pour les
this
5 prochaines années.
priority in our
Grâce à
strategy
cette
for the next
stratégie,
5 years.
plusieurs
Healthcare
départements publics et
Excellence
privés
Canada
ont
has been
amélioré
committed
la
for
qualité et la
several
sécurité
years
des
now
services
to
aux personnes
improve the
âgées
quality
dans
and
les
safety
établissements
of care and services to older
médico-social,
adults
à domicile et en
throughout
soins non
the continuum
soignants,
of
en
care, from
particulier au sein des
primary
départements
care
œuvrant dans les
to
services
long-term care,
support sur les
including home
territoires
care,
nationaux.
and this together with many
Donc, l'objectif
partners
demeure toujours de
in
donner un
provinces and
témoignage
territories as well as
de la
Canada-wide.
collaboration avec nos
The
partenaires
objective
afin
remains
d'améliorer
to
la
have a
qualité
collective
et la
impact by
sécurité aux personnes
working
âgées
with our
et
partners
implémenter
in
des
order to
stratégies
improve the quality
adaptées
and safety of
qui
care
incluent
to older
répondre aux
adults
besoins d'une population
as
vieillissante.
part of the
Donc, on
network's
pourrait des
strategic
exemples
priorities in
de
order better to meet the needs of an aging population. So a few examples of the projects that we've supported related to population aging. In primary care, we have a collaborative project that is intended to improve care of vulnerable individuals in the community setting. We also have a partnership with the Canadian Partnership Against Cancer, which provides essential home care to patients suffering from cancer or another illness that shortens their life expectancy when they need it and where they need it. We also have a number of projects in the area of long-term care, including SLD Plus, which provides support throughout Canada in the context of the pandemic. The key objective is to create a practice community working together in order to reinforce pandemic response. And we have a collaborative project in Quebec called Opus AP PEPS, which intends to implement a non-pharmacological approach and personalized care in order to reduce the number of potentially inappropriate medications prescribed to older adults living in long-term care homes. I will now turn the meeting over to Rachel Rouleau, an expert pharmacist who supports the planning of Opus AP PEPS since 2019 in long-term care homes in Quebec, and she will share her experience with us related to the dissemination of innovative practices in care and services to older adults. Thank you very much, Tania, for your kind presentation, your kind introduction. So the challenges related to the network are many, and they are concerning at two levels, aging of the population. To give you an example, here in Quebec, and it's probably similar across Canada, within a few years, some pathologies, such as neurocognitive conditions, will increase by 50% in terms of prevalence. So if we don't change our approach to care, if we don't personalize our approach to patients, we will have to improve our hospital capacity and long-term care capacity by 50%, which is not exactly what is being planned, because we are right in the middle of this geriatric pathology and syndrome growth. And there's also the scarcity of human resources. So here in Quebec, at least, and I'm sure it's the case across Canada, the dearth of human resources, nurses, pharmacists, physicians, is a concern. And even here in Quebec, with compulsory vaccination, it's a very difficult timing that we're faced with. So, thank you very much, Healthcare Excellence Canada, for allow us to bring the Opus AP process together with PEPS, so to bring those two projects together. Why we're interested in bringing those two projects together and deploy them throughout our long-term care facilities? Well, the Opus AP approach, that is to say, better use of antipsychotics in long-term care settings, has already proven with beyond a reasonable doubt the benefits of this approach, both for residents and for staff, because we tend to forget this. But when we reduce potentially inappropriate medications, not only are residents doing better, but they also have fewer behavioral issues. It's ironic because those medications are administered in the first place in order to deal with behavioral issues, but there are fewer problems such as falls and so on. So the reduction of antipsychotics has proven its worth. And the PEPS deals with patient-focused care, personalized care, in terms of drug therapy, but also the entire care process in long-term care, in order to improve effectiveness, in order to improve specificity, and in order to improve personalization of care for each resident. So medication, of course, I'm a pharmacist. You see my happiness pills are in my background. And that is my bias, but let's take medication. Medication prescriptions will be personalized for each resident, for their situation, and decision making related to medication is personalized based on care delivered to residents or their peers or their family. And so we'll collaborate in adjustments to medication and to prescriptions, and we will try not just to respect their wishes, but to apply them to the letter. All that meaning that ultimately our long-term care, the long-term care we dispense, we deliver is much more adequate. There's a great deal less potentially inappropriate prescriptions. We decrease them by 50%. There is a lot less polypharmacy with adverse interactions, adverse drug interactions that are very frequent, and our residents are more comfortable. And all the staff in long-term care is motivated, is mobilized, because the very essence of the personalization project of PEPS is to bring the full skills of each stakeholder. So physicians try to focus on very specific medical care. Pharmacists, a team of pharmacists, focus on medication in starting, adjusting, and titrating down medication as well, depending on the needs of each resident. And the nursing care team focuses on nursing care evaluation and screening. So we mobilize our teams and we create a new time. If we decrease polypharmacy by 50%, of course, we give extra time to care teams because they don't have to administer all that medication. I'll give you an example. One drug we use to treat cholesterol that could prevent cardiovascular events a few years down the road. If the person has a much shorter life expectancy and doesn't tolerate the medication, well, if we take it away, we won't need to follow that medication, nor the drug interactions, the adverse events, less lab work. So the nursing care team will have more time to adopt a non-pharmacological approach, for example, to behavioral issues. So we're very happy to work on the implementation, deployment of this process. The Opus 1 and 2 phases have been completed in Quebec. The results have been published in JAMA, prestige US journal that you can easily find online. And in order to give you a little background, in Quebec, generally speaking, this approach will be the approach that is we required at the very large scale. We intend to deploy this approach throughout all retirement and long-term care homes in Quebec. The Opus AP PEPS process in all the facilities. And one project that the current government is proposing, that is to say, building alternatives for elder care. That is also the approach that is intended for all those new facilities. So it's a work organization approach where the resident and the family are at the heart of decision making. So just to reach that goal, a number of documents have been published, including a accommodation policy in Quebec that has been deployed. We've also developed ministerial approaches to long-term care homes and retirement homes. Other projects are ongoing. So in terms of ongoing projects, all long-term care homes will be equipped ultimately with electronic medical records, electronic prescribers, and will have a work organization that will be innovative and focused on the needs of residents. Maybe another detail before we open the question and answer session. Still, in the spirit of continuous improvement, there is a Café du Monde in Quebec, a World Café that is planned together with HSO, that's the standard setting organization in health throughout the country. All the accreditation standards are applied in Quebec, and that World Cafe is planned for October 20th. If some of you would like to participate in that session, it would be possible to participate in that World Cafe. So is this enough, Tanya, for the presentation? It's perfect, Rachel. Thank you very much. So thank you for all these reflections. So there are a number of challenges in the system related to elder care, but a number of reforms are happening as well, especially in response to the pandemic. So now is the time to repost our question for this discussion group. I would ask our team to please post the question. What would meaningful improvement in this area look like? New policies and practices for work organization and care and service delivery will help integrate healthcare and social services in order to improve results. So what would meaningful improvement in this area look like in terms of care and services for older adults with health and social issues across the continuum of care? The idea is to support healthy aging of the population as defined by the WHO. So over to you, all those who are with us. What would meaningful improvement in this area look like? Is there someone who wants to break the ice? Meanwhile, Rachel, do you have ideas? Yes, I might add a few words while everyone is thinking. With the challenges that we've discussed, population aging, the fact that the population with major cognitive and other conditions in the geriatric population will be doubling in size, we will have to rethink our organization. And generally speaking, I believe that we should try and keep these people healthy at home, in the place where they were living, much more than relocating them into the long-term care system. I see that there's a few things in the chat box, but I think that is one of the key premises. Otherwise, the healthcare network will be quickly overwhelmed. There's a question for Rachel. Okay. So what support is available for patients when medication is reduced as part of the medication reduction process? Well, in terms of patients at home, there is no specific intervention except that it requires goodwill and cooperation from their family physician and their pharmacist. But in the outpatient system in Quebec, there aren't necessarily any specific project. Of course, in long-term care, we have we're a step ahead, and actually we had further to go. But for the time being, there is nothing concrete. Now, here in Quebec, it's a bit like everywhere else. We work through associations. So the Quebec Association of Pharmacists recently, in its recent negotiations relating to the reform of the Pharmacy Act, which has been a major process ongoing for a few years, I think we are as far ahead as in Alberta, maybe even further ahead in terms of the legal framework. And that's related to our PEPS Opus AP process, which has allowed us to broaden our scope of service. So reviewing drug treatment and potentially reducing prescriptions is reimbursed um, uh, service in Quebec. So this is very recent. The latest regulations were adopted in 2020. There haven't been a lot of silver linings in the pandemic, but this one was one of them. The fact that we were able to make headway more quickly on some issues, such as broadening the scope of practice to improve access. And the entire project was unfortunately um, uh, terminated in 2021, but negotiations are already ongoing for the next iteration, and over the coming months and years, all this will progress even further. Another area that will be very important will be professional governing bodies. So in Quebec, the College of Pharmacists that govern the College of Physicians will be publishing standards. For example, specific standards related to retirement homes, including home care, including so not necessarily just private homes, but there will be anyway. The standards will include requirements for professionals to review medication. So the support will take the form of this requirement and also the resources to pay for that. And I think that's a major step in the right direction. Another comment, coordinating care within the community with visible access for families in order that people can age at home. Do you have any reflections related to that concept? Yes. So those programs aren't necessarily highly developed, but if we take from the top of the pyramid, I think our governments have rolled up their sleeves. Uh, at the pan-Canadian level, the CRA does offer specific deductions for people who have reduced autonomy but who would like to remain at home. There are income supplements to access various services, and we have the same thing in Quebec. So both levels of government are supporting families, are supporting caregivers in terms of tax policy to help people stay at home. I think it's a step in the right direction. But if I might put in a plug, put in a message, those programs are not targeted, and the documents used to access them are not specific, and they're not well known. What people have to apply for is the deduction for disabilities, whereas it's really people who are semi-autonomous and must and want to remain at home. But the program is called disability. So it's the process is not necessarily made easy. You have to fill out forms, and these people may have limited access to internet and so on. So it's not easy. Maybe an organization could help, but at least this is in existence. But coordination remains a challenge for sure within the system. There's a note that the presence of professionals other than nurses and pharmacists, including occupational therapists and physiotherapists, are important in maintaining health and quality of life of long-term care residents. So duly noted in terms of existing models. I think pharmacy, nursing, and physicians are the trio that are at the forefront. Yes, we have that kind of triumvirate. It's the core, and we're used to it as a default. But it's very relevant, not only in long-term care, but physiotherapists and occupational therapists are important in long-term care, but also at home in home care to help people stay at home in good health. They are vital. there's no pharmacists at home, no public pharmacists. Those are private pharmacies that serve these people, but our occupational therapists and physiotherapists that will allow people to adapt their environment, to avoid falls, complications, or who will be providing tools to people to allow them to stay at home. Of course, it's extremely relevant. Another suggestion or lead: at all levels of healthcare, there is a need for national, provincial, territorial, and local policies in terms of care service planning and delivery, understanding that older adults are not monolithic. This must be done in a spirit of equity, access to all to services in the community so that people can live where they want to live in good health for as long as possible. Yes, I saw that you shared the national standards in Quebec. We have our policy, and we're very, very happy since 2017 that we were able to implement a personalized long-term care project, the PEPS project that is now twinned with Opus, piece in order to personalize our entire approach to patients' care levels, care needs, without using a one-size-fits-all approach. And also, question about especially for private retirement homes and long-term care homes, how can we increase their accountability in terms of legislation, in terms of policies, and in terms of medication? This remains an issue. Yes, I agree. Private homes, I know that in Quebec, there will probably be changes. We have public and private LTC, and in the private sector, we have agreement sector, the non-agreement sector, and all that will change. The pandemic has taught us things, fortunately, and we will be applying those lessons. And those labels will probably change, and probably all private homes will be in the so-called agreement sector. So they will have specifications, they'll have standards to meet. And the other part is the professional governing bodies, because when you're private, it's the physician, the pharmacist, the occupational therapist. So I think professional governing bodies will have a role to play in order to set a minimum acceptable level of professional practice in those institutions. So those are all excellent ideas. Another comment, which is also relevant, the safety and quality paradigm. So how can we make sure that safety and quality work hand in hand without creating silos? Right. This is an excellent comment. And sometimes, and we could add well, not just quality, but also care, the wishes, what residents wish to have in terms of care. If we try and standardize everything, sometimes you're leveling down in terms of safety. Sometimes you can also level up. But I'll give you an example. If somebody would tend to have a lot of falls, and certain measures were taken to reduce falls, but that those measures would be a constraint in terms of cognition or social contact. Let's say you had a chemical chemical restraints. Well, if you lift them, then the person may move around more and fall more. So sometimes you have a compromise between safety and quality, or between patient wishes and quality. But the best way is to share the decision making with residents, with the family, and therefore with caregivers. Therefore, you put your cards on the table, and the choice will have been made that is the most appropriate choice and the right one. Okay, one last comment to inspire people. What can we do to encourage more professionals in the area of gerontology? How can we make sure that this is a sector that is valued in the healthcare system? I think that's a very relevant question as well. Yes, this is a very relevant question. As I was saying earlier, we were lucky to some extent with PEPs because the collateral damages, as it were, of the PEPs process can be obviated by vesting responsibilities in the care team. It's not just up to the physician to make all decisions. The pharmacist can take over part of the decision-making burden, and according to the scope of practice, they have them. They just don't use those prerogatives. So, as a joke, I would say if a physician prescribes medication wrongly, and the pharmacist um, fills the prescription, both will go to jail. I mean, I'm joking here, but the pharmacist will stay in jail longer. So pharmacists really have the main responsibility for the medication, for the pharmacotherapy. So leave it to professionals to take on responsibilities. Contrary to what we might think, it's motivating, it's inspiring for members of the care team. So I think that's something that we can't forget in we make people's jobs interesting, and that's motivating and that's mobilizing in terms of additional responsibilities. Thank you very much. Thanks to all of those who participated in the chat box with your suggestions, your proposed solutions. And I will conclude with a comment about relational patterns of interactions. I think that summarizes what you've been saying, Rachel. We have to focus on residents' wishes, and we have a lot of suggestions for solutions in the chat box that we will use to inform our strategy over the next 5 years. Today was the first opportunity to engage with you, so we'll continue the conversation. You can check out our website, you can join the conversation on social media, and you can also register for Canadian Patient Safety Week. Thank you very much, Rachel, for this extremely stimulating discussion. Thank you for sharing your thoughts with us today, and thanks to all those who participated in this discussion group on older adults care. Thanks, Tanya. Bye-bye.